All right, good afternoon. Thanks for being here today. I know a lot of faces out here. There's some that I don't know, so if you don't know me, I'm Dr. Natasha Petry, pharmacist here at NDSU Associate Professor of Practice and then Clinical Pharmacogenomics Pharmacist at Sanford Health in Fargo. And enough about me because we have so many exciting slides to get to today. I have no relevant financial relationships to disclose. And there's our objectives for today. Basically, taking a look, basics of pharmacogenomics, and then thinking about, how can we implement it into care despite whatever setting you may be in. So when we think about pharmacogenomics, it's a piece of this idea of precision medicine, right? There's a lot of omics out there, metabolomics, and there's the microbiome, but pharmacogenomics is a piece of that. Really taking a look at genetic results and how we can use that in a couple different buckets, right? One, to help predict efficacy. Will the medication, is it likely to work or not? And then two, toxicity. So beyond side effects that are not ideal and could be annoying, there's also side effects that could be toxicity and lead to death. So a patient safety issue, if you will. And I am clearly biased, but I think pharmacists, pharmacy technicians, pharmacy professionals have a really important role to play in expanding and implementing pharmacogenomics. So human genome, many parts of it, mostly similar. Well over 99% of our genome is similar. And so the small percentage that is different, actually, we look different, right? We respond differently to things. And so that's really the small area of the genome that I kind of live in with medication response. So pharmacogenomics, again, kind of breaking down the name. We've got pharmaco for pharmacy, medications. We've got genomics for genetics and genes. And you may hear pharmacogenetics, pharmacogenomics, and they're often used interchangeably. You'll often hear PGX as an abbreviation or see that as an abbreviation. But technically, when we think about pharmacogenetics, it's specifically related to one single gene affecting the medication, where pharmacogenomics is kind of going to be that bigger, more broader, multiple genes, multiple medications, multiple responses. And while it's not commonplace yet, many institutions are using it as commonplace and a piece of that clinical puzzle to help guide therapeutic decisions. So here's sort of a pictorial, right? Before we knew much about pharmacogenomics, we had a whole, group of people, and they all take the same medication, and some respond differently than others, right? Some it's working for, others it's not. Some it's having side effects, others it's not. And we know that there's lots of things that play a role in medication response, right? So I'm not going to stand up here and say genetics, pharmacogenetics is the one and only thing that we need to keep track of, right? All these other things, diet, ethnicity, zip code, kidney function, liver function, et cetera, play a role. But some of the genetics can help explain then, well, why did someone benefit and why did another person not? Why did someone have side effects? Why did another person not? And we can break these out kind of into different responses and what we'll call metabolizer statuses when we think about the CYP enzymes. And so what are some things that we look to for pharmacogenomics? Really honing in on that precision medicine idea of personalizing a medication choice, the dosing, maybe even what monitoring we do based on a patient's specific results. So hopefully improving efficacy, hopefully decreasing those side effects and toxicities, and then reducing that trial and error, which we know can be especially important in something like depression and anxiety, where we're looking at 12-week trials to see if something works. So really helping to kind of tailor what might work and reduce that trial and error. Different susceptibilities to adverse effects, and then this is kind of just getting back to that idea of some people might need 2 tablets, one might need a half to get the optimal dosing. just some basic definitions, kind of make sure that we're on the same page. That genotype is what we are seeing reported out in a genetic testing result. And the phenotype is what we are observing. So in pharmacogenomics, this is generally like metabolizer status, rapid metabolizer phenotype versus a poor metabolizer, for example. And so what are some of the benefits? I've already talked about this. I like to talk about it a lot, but that drug safety, patient safety standpoint of avoiding those toxicities and side effects. And in the case of something like DPYD and some chemotherapies, that can mean preventing death. And so we're going to use it for that reason. Increased efficacy, which I've also already kind of talked about. Maybe it's a medication, maybe it's just the dosing of that medication. And when we think about pharmacogenomics, it can be for more than just prescription medications. There's guidelines out there for some OTC medications, like NSAID, so ibuprofen as an example. Omeprazole is another example of something that's available over the counter, but that there's pharmacogenetic guidelines for. So it gets back also in this area, make sure we're doing a good medication reconciliation, right? So we know those OTCs they're on, there may be pharmacogenetic implications. Reassurance, in some cases, it's just, giving the patient the peace of mind, like, okay, what I'm on or what the provider is putting me on is something that based on my genetics is okay. Now, it doesn't always match up, right? But it can help provide reassurance and it can provide validation. So I had a patient who was not responding to opioid therapy. They kept telling their provider, like, it's not working for me. I'm not getting pain relief. I need something stronger. I need a higher dose. They kind of got labeled as a seeker, and we got their pharmacogenetic testing results back that showed genetically they shouldn't be getting much pain relief from it. So that was some good validation for them to say that, it wasn't in their head, that it really wasn't working and that there was a reason for it. Self-advocacy of patients. So we find a lot of patients will come into our health system and ask for a genetic test. You're starting to hear more about it in the news. There's some, direct-to-consumer companies out there, and it's another way. I think, especially for patients who've had a lot of trial and error or had adverse effects, they say, like, I just feel like I want this as that extra piece of information, or maybe they've tried so many things and they're like, it might work, it might not, but I've tried so many other things. Like, I feel like, I need to check this box as well to take care of my own journey in this health issue that they're going through. Now, not for every place, but some places are able to embed pharmacogenetic results into the electronic medical record, and so it can fire alerts, just like an allergy or duplicate therapy or things like that. And that can really help because we know pharmacogenetics is not widely taught in health profession schools, and so if we can embed it, alerts into the EMR, that can help guide professionals as they try and prescribe medications that might have genetic implications or interactions. So it's our genetics. So it's really, it's lifelong. Once you get a test, your genetics per se aren't going to change, right? So we're not repeating lipid panels and expecting different results. Now, as it stands now, most of these panels only have probably about 20 genes or under that we're testing for. So is there the possibility that they might need tested again in their lifetime? Yes, as technology improves and we have more things that we're testing for and more guidelines. But again, the information that you have at that time of testing is lifelong. And then medication safety, and I think I've talked about that plenty already. And so again, it's just only one piece of the puzzle, but I think that it's a really important piece of the puzzle. But that's certainly a limitation. Is we have seen patients come in with the expectation that, like, I'm going to get this test, it's going to tell me everything that I need to know about all the medications that I'm on, and that's just not the reality at where we're at this point. Maybe someday in the future, hopefully. But other limitations include cost. Now, the cost has come down significantly over the past few years. However, most insurances are still unwilling to cover the cost of it, so it does a lot of times end up being out-of-pocket cost. Now, somewhere looking at between $250 to $500, and the last time I kind of did a lay of the land of costs of these tests. Now, in limited cases, they will be covered by insurance, and you can certainly try prior auth, but cost, I think, is one of the big limitations that we're facing in this field currently, along with the limited insurance coverage, which ties into that. Again, it's not going to be everything for every medication. So we have guidelines right now, evidence-based, multidisciplinary written peer-reviewed guidelines, but only for a handful of medications, which I'll go over later so you can kind of get a lay of what those look like. As we get more information, we'll build on these guidelines. But for right now, there are some disease states like diabetes that are very common, but we don't have a lot of pharmacogenetic information currently. Standardization is a big issue, especially for labs' approach to testing. And so some labs may test for only 2 variants, while another lab might test for 20 variants. And how it currently works with single nucleotide polymorphism testing, SNP testing, where you're kind of just testing spaces on the genome that you know that there's likely to be a variant, something that would change the way that the patient responds. If you don't find anything at one of those variants, they're being reported out as wild type or normal. And so the problem is when you're not testing for the proper SNPs, the very common SNPs on the genomes, they could be missed, and you could incorrectly classify someone as a normal metabolizer when actually they're not. And so I know, like my personal stories, I've had pharmacogenetic testing from 3 different companies, and my CYP2D6 was different at all 3. And so, fun for me then to go back and be like, oh, well, which SNPs did this one test, and it must have missed this one because that's the one that I have the variant in. But that's not very common knowledge to people who aren't in the field, or to patients like trying to explain that. So I'd like to call out that there really needs to be some standardization. A bunch of organizations in our field are working for like tier 1, tier 2, tier 3 genes. And so we're hoping to get to the point where if you want to be seen as a reputable pharmacogenetic testing company, at minimum, you'll be testing all the tier 1 genes. And then race, ethnicity. When I talk about those common places on the genome where we find the variants, most of that information is coming from our European population because that's the base population that we've had. Now, over the past 20 years or so, we've done a really good job of getting more diverse samples to base our testing off of, but there's still some gaps there. So when we see someone reported out as a star 1, which would be normal, sometimes we can question whether they're actually normal, or maybe they just have a variant that we don't know to test for yet. All right, I don't have to talk to this crowd too much about PK and PD, but we'll just kind of skip through these pretty quickly, thinking about those in relation to pharmacogenomics. We'll do that just a tiny bit today. So thinking about PK and ADME, and specifically with the liver, this is a lot of where we're thinking about our cytochrome P450, and a lot of pharmacogenetics right now is related to those CYP enzymes. CYP2D6 being a very common one, where that metabolizes 20 to 25% of the most commonly used medications. So that's a big one, and then some others as well. But pharmacogenetics is much more than just metabolism. We have transporters, and so here we see SLCL1B1, which plays a role in statins, statin transport. And this kind of talks about, when we think about our drug-gene interactions, and dividing them into PK and PD, and then we have metabolism, which is where we have the most evidence for pharmacogenetics. And then we have some transporters, receptors, and sensitivity. And there's a lot more research that needs to be done in all areas, but specifically more on this end of the spectrum. So most of the information that we'll be using currently is kind of more in this metabolism space, a little bit more in this transporter space. And so when we think about the types of drugs, active drugs versus prodrugs, this really matters when you're trying to get a grasp on pharmacogenomics. And if you're a poor metabolizer, what does that really mean? Versus if you're an ultra-rapid metabolizer, what does that really mean? So remembering the active drugs absorbed and distributed, broken down, and then excreted, active right away, compared to the prodrugs where it's inactive before that metabolism. So oftentimes we need that CYP enzyme step to make it active and have it work. There's a few, common examples of this, one being codeine to morphine. Also, clopidogrel is a very well-known prodrug in the world of pharmacogenomics. And so trying to compare these then, if we think about active drugs, all right, it's working right away, goes through that metabolism, to be broken down, not active anymore, versus our prodrugs, not really working, but then goes through the metabolism step to start working. And that is going to be important when we start thinking about kind of the action. All right, so in our active drugs, you've got ultra-rapid or rapid metabolizer, that increased activity. All right, going through that medication pretty quickly, and oftentimes then that drug is not sticking around in the body enough to have a therapeutic effect. Versus normal, what we would expect, and then decreased, wow, it's like sticking around a lot longer, higher concentrations, at increased risk for side effects. Once we think we have a handle on that, then we take a look at it from the standpoint of prodrug. All right, so we need this metabolism to convert it, right? So, all right, we've got this inactive drug, increased activity. All right, we've got like a lot of action going on here. And this is where it can get dangerous. If you think about taking something like codeine, the 2D6 converts it to morphine, and if a patient's an ultra-rapid metabolizer, it's getting converted to morphine really quickly, and that's what can cause that respiratory depression and even death. Versus if we have, say, for example, a poor metabolizer, so if this is clopidogrel and we need this metabolism to make it active and for it to work, this is broken. So patients taking clopidogrel and it's not working because of the genetics. And so there's kind of a little bit of a difference there when we try and get a handle of rapid versus in an active drug versus rapid in a prodrug. All right, and so I'll cover this more in the next slide as well, but just thinking about when we think about pharmacogenetic results, they're being returned as a diplotype, and so we have two alleles. Both may have varying function. One might be varying and one might be normal, and when I say varying, it could be increased function, it could be decreased function, could be no function at all when we think about coming to poor metabolizers. And so this is kind of what it looks like when we think about the genetic definition of how many functional alleles do we have versus our functional definition of kind of what's the level of enzyme activity that we're seeing. And a poor metabolizer has little to no enzyme activity at all versus ultra-rapid is that increased enzyme activity. So that kind of makes sense when we're thinking about definitions. Now, normal metabolizer, there is one company that still reports it out in the old terminology called extensive metabolizer. So if you see extensive metabolizer, that also means normal metabolizer. But there was a group that got together years ago now and said that there's some confusion with the term extensive, and so they wanted to change it to normal. Now, this is a conversation still ongoing in the field because some people feel like if you're not normal, then they don't really like the descriptor or what patients might take away from that as well. So terminology talks are ongoing, but normal or extensive are interchangeable. All right, so when we think about the therapeutic window, we think about drug concentrations, and we think about, maybe a new drug that we were testing, or we see a drug that's already out there and we're measuring response. Before, again, we had the general population, and then we see, some are falling in a wide variety of ranges, and that's just what we've come to expect. Versus when we're able to then break them out based on genetics, we can tie that more closely then to see, okay, well, ultra rapid metabolizers, they're getting rid of that drug pretty quickly, so their drug concentration is lower compared to a poor metabolizer that's not metabolizing as quickly, medications building up in their system, and they're having that higher concentration above the therapeutic window. So it can kind of help us. I really like this, at least like as a pharmacist, kind of thinking through, and I'm a big color person too, so I'm a fan of this chart that I cannot take credit for making. So it's a lot of information, right? You're trying to wrap your head around metabolizer statuses, and then active drug or prodrug, and what that means. And I get that. But I was hoping that this would at least help kind of if you take two drug examples. I've been trying to build this in throughout as well. But say, for example, citalopram, they're CYP2C19, rapid or ultra rapid metabolizers, so they have that increased function. They're just metabolizing it really quickly. There's oftentimes not enough concentration to build up in the blood for it to work. And so they're just not getting those therapeutic concentrations. So ultra rapid citalopram active drug, just that lack of efficacy is probably what we're going to expect. And pharmacotherapy failure versus that poor metabolizer, higher risk for side effects because there's more of that drug building up in their system, staying there for longer. Clopidogrel is the example that I already used a few slides ago. And so specifically paying attention to the poor metabolizer status, the lack of efficacy there, which of course then can lead to increased side effects, which we saw in this study here, looking at major adverse cardiac event rate and looking at clopidogrel and CYP2C19, noting that the loss of function clopidogrel, so our poor metabolizers of CYP2C19, had a statistically significant higher cardiac event rate. And then when we take a look at how clopidogrel is metabolized, just to visualize, the stars represent CYP2C19 in the process. So seeing how CYP2C19 is needed to convert clopidogrel into active form. And then when we think about transporter genes, SLCO1B1 is a really good example. Here's a pictorial of simvastatin, and that needing SLCO1B1. And so when we take the medication, we take the statin, and it's in the blood, we need the SLCO1B1 transporter to bring that simvastatin into the liver, or bring that statin, whatever it is, into the liver. And so if we have poor function of that transporter, then the statin's hanging out in the blood, increased risk of side effects like that statin-related myopathy, versus if we can transport it in with our normal function. HLAs are one that we think of a lot in pharmacogenomics. These are really hard to test for in the lab, so not all companies will report all of these out. But some serious side effects like SJS or TIN that we can prevent by having this pharmacogenetic information on hand ahead of time. And so I think there's a lot of intricacies related to pharmacogenomics, but one of the most important things is like if you have the information, how to use it, right? And so ClinPGX, which was formerly PharmGKB, so if you've ever heard me talk before and I scream like, remember PharmGKB, now I'm gonna say, remember ClinPGX. And this is where you can go, type in a medication name, it'll bring you to any guidelines, any FDA labeling. It will help provide you with information on what to do if there are evidence-based guidelines. The FDA also does have a table of pharmacogenetic associations. So if you're wondering if there's anything about pharmacogenetics in the label, that's a one-stop place that you can go as well. CPIC is a guideline body for pharmacogenetics. They don't always match up with FDA, but if you go to ClinPGX, that's one spot that kind of combines all of those resources in one for you. All right, so when we think about doing pharmacogenetic testing, we've got preemptive, sort of just, we're going to do it to have our results on hand, which is awesome because then when a patient's prescribed a medication that has a drug-gene interaction, we already know it, right? But seeing that this test is still, a considerable amount of money, we don't see this happening as often. We're more often living in this reactive space. Might be a single gene, 2C19 and clopidogrel. Oftentimes it's a panel. And this is like if you're anticipating starting a therapy, or maybe the patient's already been on a therapy and you want to kind of select a new one or explain adverse effects that have happened already. Now, I promised you that I'd sort of mention which medication classes have guidelines. And so if you go to CPIC or ClinPGX, you can click on that. I try to highlight some of the more common medication classes. And so PPIs, we have guidelines for those, NSAIDs, SSRIs and SNRIs, and opioids. So those are some common areas. Also metoprolol under beta blockers, TCAs, some chemotherapy. So I didn't highlight all of them. But there's all of these here, medications, as well as here with statins is the one that I highlighted on this slide, but we also see some HLAs with the bacavir. And I know it's small, and so I'm not expecting you to read all of it, but I wanted you to see that there are, a decent amount of medications that we do have guidelines for, and some fairly commonly used medication classes. All right. So just when we think we're getting a handle on it, right, there's this thing called phenoconversion. And phenoconversion, really more simply, is just like a drug-drug interaction, right? Strong inhibition, like we've learned about it in school before, if you're in pharmacy school. But it adds another layer of complexity, which I think adds to the importance of pharmacy professionals being in this space. You might have an ultra-rapid CYP2D6 metabolizer, but if they are on a strong 2D6 inhibitor, paroxetine, fluoxetine, bupropion, quinidine, it's going to knock them all the way down to a poor metabolizer. Their activity score might be 6, and if they're on one of those meds, it's going to be knocked down to 0. But it's not going to really show up on the pharmacogenetic report, right? The pharmacogenetic report is the genetics. But then we have to say, oh, they're on one of these medications, and recognize that while they're on one of these medications, they're acting like a poor metabolizer. When they go off of the metabolizer, or when they go off of the phenoconverter, they retreat back to whatever their genetic status was. So take them off that medication, they revert back to normal if they were normal. There are some phenoconversion resources. So the Flockhart table, also it's really small. I'm not expecting you to read all of it, but just to remind myself that what I love about the Flockhart table is it actually classifies the inhibitors strong, moderate, weak, to be determined. And it has started to do that with the inducers as well. And so you can kind of get a lay of the land of what that looks like. And then you can use the University of Florida phenoconversion calculator to see what that means. Currently, it's only for 2D6. They're adding in 2C19 soon, from what I hear. But it will take you, if you have a patient, you enter in their star one, and so they're normal, their activity scores 2, and then it allows you to select like, oh, they're on duloxetine. So you click that, and it says duloxetine's a moderate inhibitor, which knocks their activity score in half. So it says now their activity score is 1. And then you can use that information to enter into ClinPGX to find out your recommendations. Now knowing my time's escaping me so quickly, pharmacists we're really well positioned, pharmacy staff, to be in this, to help explain to patients, to help explain to other health professionals, to implement it, to do all sorts of things and collaborate with others. And so one of the really fun things that I I think PGX has been incorporated into is warfarin dosing. And so there's a warfarin dosing calculator. So I've said like, oh, there's lots of pieces of the puzzle, right? So look, like height, weight, do they smoke or not, other drugs that they're on, but also there's this whole section on pharmacogenetic information. And so that's just one example of where we're kind of seeing pharmacogenetics incorporated into everyday care. Now, thinking about models of delivery, there are a lot of health systems that are doing this. Might be provider-led, might be pharmacist-led, could be an interdisciplinary team getting this done. And I won't go into too many details given the time that we have left. But there's also tons of PGX consultation services out there. So pharmacists have their own consulting business, and they are ordering the testing, getting results back, meeting with patients, and interpreting it. And then there's some great articles that I've seen and heard a presentation about community pharmacist-led, recommending the testing there, talking to patients. Some are incorporating it into MTM visits. So there's lots of ways that it can be done. Now, oftentimes, if you're doing it in a community or retail pharmacy setting, it's going to be direct to consumer. And so you have to be a little bit careful with the quality of the lab that you're going through. And then also, before when I said about the tier 1 alleles, you want to make sure that at minimum they're testing the tier 1 alleles. And also with some direct to consumer companies, they're not considered clinical by the FDA. So if you think of, 23andMe is always a go-to example. Their CYP2C19 was clinically validated, so you could use that for citalopram or clopidogrel, but their other pharmacogenetic results weren't. So technically, you would have to get it repeated by a clinical lab. So it's not always the most cost-effective for patients, but there is some work in that area to sort of remedy this. All right, and so as far as workflow, we all know that that's important when you're starting a new service. I know there's at least another talk about that today. I just really want to highlight this article here or this document. If you're in community pharmacy, you're interested in implementing this. This was a case study they did. It has all sorts of great information. Make sure you're assessing readiness, establishing a workflow, collaborating with providers, identifying suitable patients. You get the results, and maybe it's direct to consumer, but maybe you have a collaborative practice agreement so that you get it more through a health system directly. And maybe it's stored in electronic health record, maybe not, and then you can help interpret results. And of course, provide a recommendation. Here's some other sort of build on what has been done, some articles that may be of interest to you if you are in the community setting and thinking that this might interest you. And then some key takeaways really is that pharmacogenomics is just taking genetics, looking at how a patient responds to medications. We're hoping to help improve efficacy and minimize toxicity and side effects. And you're not expected to know everything about this, right? But just know your resources. ClinPGX is my major recommendation. That includes FDA and CPIC. And we have a case study that unfortunately we won't have time for, but basically, the spoiler is that this patient was on a phenoconverting med, and so we want to monitor their metoprolol, which is metabolized by 2D6, for some bradycardia and dizziness. And then we're going to maybe change their PPI because they are a rapid metabolizer of CYP2C19. So we could consider increasing their dose. All right, that was a whirlwind. I'm sorry we don't have time for a roundtable discussion. Thanks to all of you for being here. And thanks for a couple of APPE students who helped me with put together these slides. Available for questions, and I'll try and, I have a meeting to sneak out for, but I'll come back so you can snag me during a break or afterwards if you have questions. Okay.
Thank you, Natasha. That was really good. I feel like I learned a lot in that very Very good presentation. We actually do have time for a round table, so everybody can get out their sheets at their table. It was part of your packet. You can see the round table discussion points. And how we're going to do this is we're not going to be reporting out. So this is just to spur discussion amongst the